So this is what we're going to discuss today, resting in hyperemic indices for serious stenosis. Now we all know the underlying principle of the FFR. This is what has changed the way we look at our intervention over the last 2.5 decades or so. We know that we're trying to we are measuring pressure, but it's a surrogate of flow. And we know that flow can thus be altered by changing both pressure or resistance. There are robust autoregulatory mechanisms to keep flow constant at rest. These are mediated by microcirculation, and when they exceed physiological limits is the problem of ischemia that occurs. Now, flow is pressure by resistance, and if resistance is thus kept as close to constant as possible using adenosine, then flow is proportional to pressure. And when you take a ratio, we can eliminate the resistance, and flow becomes almost equivalent to the difference in pressure. Thus, we are able to assess stenosis and determine whether it is flow limiting from a pressure recording that is recorded during the maximum achievable flow. The true definition, thus, is the maximum achievable flow in a stenotic vessel divided by maximum flow in the same artery without stenosis at maximal hyperemia. Now, the resting indices, the IFR principle essentially depends on identifying a wave-free period, a phase of the diastole from 25% to 5 milliseconds before the end of diastole. The assumptions that are made for this measurement is that the coronary microvasculature, the resistance offered by the coronary microvasculature is constant during this time. The resistance offered is minimal, and the PDPA ratio during this interval is thus directly proportional to flow. And this is a surrogate of coronary flow during maximal hyperemia because the pressure gradient is maximum, flow is maximum in diastole. This is the wave-free period. Noise from compression and suction waves is minimized. Resistance is constant, so the change in pressure is proportional to change in flow. Velocity is higher, so there's a better power to discriminate, and there's no requirement for hyperemia. These are all the assumptions that are made, and this is the concept of the IFR, that phasic resistance during the cardiac cycle. Now, IFR can be measured either on a beat-to-beat basis or on an average over several beats, and this distinction becomes important when we're looking at serial stenosis, as will become apparent on the subsequent slides. The problem of serial stenosis is a curious one. Now, the top half of the slide shows the difference between what happens at rest and what happens at hyperemia in the presence of a stenosis. And whenever there is an increase in the severity of the stenosis, the ability of flow to increase to the hyperemic stage actually comes down, and this is what we're trying to correct by performing a percutaneous intervention and take this curve back from here to here, that the hyperemic flow improves, but the resting flow is going to remain the same regardless of IPCI, and that's an important distinction to make. Secondly, the severity of the stenosis, when there are two tandem stenosis, the rest and hyperemic flow pre-PCI remain the same, but post-PCI of a different lesion is going to now leave only the surrogate of the remaining stenosis in that particular vessel. Thus, the first or the proximal stenosis is going to overestimate the significance of the distal stenosis, and the distal stenosis leads to an underestimation of the significance of the proximal stenosis. Now, there is theoretically a way to divide the amount of stenosis relatively contributed to by both these. Thus is the predictive FFR. This has been around for the last 20 years, but it involves completely occluding the vessel with the balloon and measuring what is called the pressure wedge, or what is the PW. So if one looks at the predicted FFR of A, this is P3 minus P2 by P1. You can see P3, P2, and P1 labeled here, divided by the pressure. PW is the pressure wedge. That means the pressure measured when there's no flow in the vessel. And this is a rather cumbersome step and can be done in research, but very difficult to do day to day in the laboratory. Why are we worried about all this? Why not stent the whole thing? So if you look at some large data, full metal jacket or multiple or overlapping stent implantation, event rate is not too bad. 7.1% at the end of 720 days is not bad. So why are we so worried about serial stenosis and trying to figure out how much? So let's look at this data a little more carefully. When you look at multiple overlapping stent implantation, the 2-year MACE actually is closely related to the number of overlaps and the number of stents that are implanted. If one uses only one, it's 4.4, and if one uses 4 or more, it's about 9.1. That means it's twice as much. So that means that 7.1 could have actually been much, much closer to 4 if we had actually not used a full metal jacket. And thus, we want to implant as little as metal as possible. That is intuitive. And in the correct place if possible. Now, this is the way in which we look at FFR. If we look at FFR of B, that is the stenosis B, this is the PD by PM, PD by PM. And for A, it is PM by PA. So this is how we try and look at the relative contributions of the stenosis, but it becomes extremely complex, as I said, to measure this. The only way to do it is by measuring the pressure wedge, which is very, very difficult to do. So thus came the concept of the big delta. That means we do a pullback with an FFR and try and figure out where is the bigger jump. Wherever is the bigger jump is the place that we stent, and then we do an FFR again and see if the second stenosis is still significant enough for us to treat it. In simple terms, if A is tighter, we treat the proximal A and then look at FFR of B, and if then that's residual and tight, then we look at it. Graphically represented, if these are the two stenosis, the total pullback across is extremely significant. You can see that it's very tight. Repeat it after treating the larger gradient, and then see it's still tight, it's 0.72, then again the distal second gradient also has to be treated. And that's what we ended up doing most of the time. They tested this hypothesis in the real world. PCI was performed in tandem lesions, first for the lesion that showed the larger change in FFR, and then reassessed for the remaining stenosis. And if it was less than 0.8, PCI was performed under IVUS guidance. And this is what it looks like. There are two stenosis A and B. You see the overall FFR is quite tight, distal, mid and proximal. This is a pullback under full hyperemia. After the first one is stented, we still have significant FFR, 0.72 across the second lesion. And so the second one also has to be done. Another situation where there are two tandem lesions. Here, the greater pullback is in the distal one, and after the distal one is stented, the proximal lesion is found to be non-significant and can be left. This is what they found in this small study. 50 patients prioritized. 32 had the proximal stenosis treated first and the distal treated first in 18. FFR reassessment led to both stenosis being treated in 16 out of these 32, and the other half had only one treated, whereas in the distal stenosis it was 12 and 6. However, this did establish the way in which we could look at tandem lesions with the available physiology in those days. These were the treatment variables. 9-month follow-up showed only one target vessel revascularization with a progression of deferred lesion. Unnecessary stent implantation, thus the fundamental stones for working forward on this hypothesis occurred. Another study which looked at a large number, identical protocol, 131 patients published in JACC intervention, multiple intermediate stenosis assessed by FFR. Again, stenosis that caused the largest pressure step-up was stented first. MACE was stented during follow-up, 116 stents, and revasc was deferred in 61% of the lesions. During the mean follow-up, there was only one target vessel revascularization due to ISR and no events related to the deferred lesions. Thus, it was established that FFR-guided revasc was actually safe and it was effective. What about resting indices? Now, IFR pullback offers us a special window into the way in which these serial lesions can be addressed. The three important points are that autoregulatory mechanisms ensure that resting flow is stable. It doesn't change much regardless of lesion severity unless we go down to a resting IFR of 0.65 or less, in which case the lesion is subtotally occluded anyway. Now, the distal microcirculatory bed, that's a key governor of coronary flow, dilates under resting conditions to maintain the flow even when severe epicardial narrowing is present. And the basal state is thus uniquely suited to the assessment of vessels with diffuse or tandem lesions, giving a difference between step-up which occurs at tandem lesions or the gradual step-up seen with diffuse lesions, because basal flow across the lesion is negligibly affected by other lesions. This is what I mean. This is a diagram which we have seen earlier. This is what we're aiming for. Hyperemic flow, but rest flow remains unchanged until we come down to 6.5 or less. So we're able to assess the relative contribution with this and with stenosis severity. And there is not much interaction with these two because the flow remains constant. Thus, evaluation of serial stenosis burden of the complete vessel can be done with both. Quantification of the relative impact of individual stenosis within a diffusely diseased vessel is challenging with hyperemic indices and difficult to predict. It's probably better with resting indices. The prediction of physiological effect of treating a particular stenosis This is the next advance which has taken place, that you can probably predict what is going to happen if the relative contribution of these stenosis are addressed by doing spot stenting, by using artificial intelligence and virtual stenosis. So what I mean is this: you look at relative contribution of each stenosis to the total IFR, and you chart this as was shown by Dr. Ajit in various places. You can then go ahead and say, if I treat only one, what will happen to the IFR? If I treat only two, what will happen to the IFR? If I treat both 1 and 2, what will happen to the IFR? And then make a clear decision as to what can be done and what should be done. This is another example. This is what you do. You look at where all the stenosis is and then decide what is the maximum contribution and make an assessment based on the best guess as to which stenosis is going to give you a prediction of the post-PCI IFR result based on these models which are created. This has been validated in a paper published in 2018, where the pre-angioplasty IFR actually predicted the hemodynamic outcome in humans with coronary artery disease. These were the first results, and this is being subjected to furious research further, but it appears to be extremely promising. And this is just a case example. So essentially, this was a tight stenosis both in the left main as well as in the LAD. So when we measured the PDPA resting and the RFR, it was extremely significant across the whole lesion. We then proceeded to do an RFR pullback. This is the RFR pullback, and you can see the gradient coming up in the LAD as well as the left main. But after fixing one, we still had a stenosis and we had to fix both. So it didn't really work as far as the FFR or the RFR was concerned. So what it did show us is there was a lesion in the distal OM and one intermediate lesion in the circumflex. After stenting the distal OM, the circumflex was not at all significant, but the LAD that didn't appear significant actually had an FFR of 7.4, and then that was stented. The LAD pullback showed that exactly where the location was, and we managed with a single stent with an FFR of 0.90 at the end. Thank you for your attention, and I should be glad to answer any questions.